Hello, everyone, and welcome to Science by the Slice. My name is Philip Stokes, Education Coordinator with the UFIFA's Center for Public Issues Education in Agriculture and Natural Resources. And for today's episode, we are bringing an episode in conjunction with the Southeastern Coastal Center for Agricultural Health and Safety, one of our partner centers. And we're really going to be talking about rural health initiatives. And specifically, we're speaking with some experts that attended and spoke at our State of the Science meeting earlier this spring, Dr. Mark Holmes and Dr. Holly Cost. And I'll give them a chance to introduce themselves in just a second. But we had some really great conversations at that meeting, and we wanted to follow up in a podcast format to share some of their work and really just some of the movement that we're seeing between uh, urban audiences and rural audiences and some of the healthcare needs and differences there. So at this point, I just want to let our guests introduce themselves, tell us a little bit about who they are and where they're from, and then we'll kick off a conversation. So Dr. Holly Cost, do you want to just quickly introduce yourself?
Yes, thank you so much, Phil. I'm Holly Cost. I'm the Assistant Vice President for University Outreach and Public Service at Auburn University, and I lead our rural health initiative here on campus. Very committed to health. In my previous life, I was mayor of the city in small town Alabama, and that's where my passion really for healthy and lifestyle.
Great. Thank you so much. And Dr. Mark Holmes.
Hi, Philip. Thanks. I'm Mark Holmes. I'm a faculty member at the UNC Gilling School of Global Public Health, and I direct the Cecil Sheps Center for Health Services Research, both at the University of North Carolina, where I lead a rural health research center. This is funded by the Health Resources and Service Administration to conduct policy relevant research. Like Holly, I have a passion for rural health. I grew up in the thumb of rural Michigan, detasseled corn growing up, and have been committed to rural health ever since.
Great, great. Thank you so much. And my co-host for today's episode is Dr. Lisa Lundy from the University of Florida. We work together in the Southeastern Coastal Center for Ag Health and Safety. So I'm going to let her introduce herself and then kick things off.
Okay. Like Philip said, I'm Lisa Lundy. I'm a professor in the Department of Agricultural Education and Communication here at Florida. And just really excited about this conversation today. When we had the State of the Science meeting, I thoroughly enjoyed hearing from both of you. And I know that our listeners are going to enjoy hearing what you have to say about rural healthcare. So we're going to kick it off with a question really for both of you and thinking about rural healthcare and local healthcare. How do you define that? What does that mean to you when you think about local healthcare and how you talk about it with your stakeholders? And Holly, I'll let you kick us off, and then we can kind of go back and forth a little bit.
Okay, thanks so much for this question. I grew up in Alabama. I've always lived in Alabama, except a 2 year stint in Texas. But when I think about local health, I really think about my neighbors. I think about the people across our country who really need the health and the support and the access. And in Alabama, there's so many who are disenfranchised for a number of different reasons. A lot of it is distant from healthcare. We have hospitals that are closing down all over our state. Very challenging for someone to go and give birth in a hospital right now if they live in a rural area. So we really drilled down into these small communities. In fact, in one of our communities, population where we have our health initiative is 75. That's the population. Now, the broader population is bigger than that, about 10,000. But we look at where the needs are, and we also look at where the access are lacks in order to concentrate our effort. Just really getting to know the people in the community. That's what I enjoyed the most about.
What I really liked about Holly's answer is the notion of being tailored to the specifics of that particular community. As a policy researcher, we often have to define a community and we'll pick counties or something like that. But people travel across county boundaries all the time, or maybe a county's large enough to, in the South, counties tend to be smaller, but if you're in the West, you got this huge county and that's too big to be local. So when you say local, Lisa, I think about something that's tailored to how the people in that community define it, and think about the assets there and how they're what works for that. And for some places that might mean 50 miles, for some it might mean 12 miles. Depends on whether you're surrounded by snow-covered mountains or in the eastern coastal plain. So it is going to vary tremendously based on the circumstance of the community and the particular healthcare you're looking for. Local for primary care is going to be a lot different from local for maternity care, for example.
Yeah, and I think that just to follow up on that question, um, high points or big ticket items in terms of healthcare needs. What are both of you seeing at the local healthcare need level in terms of like Holly, you mentioned, being able to deliver a child, prenatal care. What are some of the other, primary healthcare needs that you're seeing?
Yeah, well, we're seeing particularly across Alabama as we have very high rates of diabetes and obesity in particular. So we're looking at those areas, cardiovascular health. We have a high incidence of individuals who have strokes. And so we're really trying to drill down into those areas and identify how can we meet the needs of these individuals, not just through the care, but also through the health and wellness education.
Seeing generally an erosion of specialty services, particularly those based in hospitals, but beyond that. So it's everything from the well-documented maternity care deserts that are developing. Surgical services are getting harder to access, oncology services, but also long-term care facilities and your nursing homes and even pharmacies are tending to disappear from rural America. And if we want to address these, one great strategy is to think about training people that are, rural aware. And by that, I mean, we know that physicians who have a rural upbringing and are trained in rural communities are far more likely to stay and practice in rural communities. And addressing that gap of the services erosion, we have some proven policy approaches.
You both touched on something, the fact that it seems like in healthcare, our professionals, I mean, they work so hard, but they get trained kind of in a one size fits all approach, right? And you just mentioned that, Mark, that that if they're raised in a rural community, they have that perspective and they know what some of the needs are. And what we talk about a lot in our center is a lot of migrant workers. And so, I mean, that's just a whole, people coming from, different countries and working different, language barriers and other types of barriers there, economic barriers. And so, I mean, what are some of those, what are you seeing between, the healthcare that is currently being provided and some of the needs in these rural communities? I'll start with you, Mark.
Yeah. I think as distance gets farther and farther, as services are disappearing, we have this promise of telehealth, which we saw really kind of help a lot during the pandemic. But it's only so useful if you don't have reliable broadband. And, for example, one solution that's often given for the dearth of mental health professionals in rural areas as well, we can do telepsych. But if your best broadband or the only reliable broadband in the community is in the parking lot of the local library, that's not really the kind of privacy that most of us want for something like that. And so we have often this gap between what the needs are and the solutions that, may work in urban settings, but don't always translate to rural. There's this history generally of trying to solve rural healthcare gaps or challenges by taking urban and tailoring that a little bit. And rural is not small urban. It's often a completely different approach that needs to be taken by people who understand their community and understand what local means.
Oh man, you totally said the end, Mark. This is good. Because what our model is centered around at Auburn University is this telehealth model. And so we've identified these telehealth, there's the opportunity and to increase access. We can use telehealth, but just like Ron said, you go into so many of these towns, they either don't have good internet service, they can't necessarily afford the internet, or they have this resistance to using anything electronic. And so one of the models that we're looking at is that we have this telehealth technology called Auburn. It's a standalone telehealth station that we're able to install in areas where there are these gaps in service. In Catherine, Alabama, with a population of 75, it's in the Shaw Community Center. And that Shaw Community Center is where they do the feeding program, where they do after school programming. In Chambers County, it's in a building that's in Alabama, rural Alabama, East Alabama. It's in a building that's a vacated health clinic, but it's right beside the Department of Human Resources and a grocery store. It's in a location where people can go, but even still, they may not want to go because they get nervous about using telehealth. And so what we do is we do multiple demonstrations in that area. We want to make sure that people come in and they feel comfortable. So I've actually driven a van load full of people from a church to the telehealth station and to have them go in and press the button and talk to a clinician. And that really increases their comfort level there. Plus, we've also identified that the gaps in services, they still apply to us. So in this building in Catherine, Alabama, we thought, great, we have internet service. We go there, it's not strong enough. There's an AT&T tower right beside us, not strong enough. Well, we partnered with the University of West Alabama. They have this grant for Starlink internet. And so now at 2 of our sites, we're using Starlink, and it is killer. I mean, the bandwidth is fantastic. We have no problems with that. So we're able to overcome some of the challenges, but then there's still the transportation barrier. Even if it's right down the road, how do some people get there, particularly if you're sick? And a lot of times it's neighbor helping neighbor, but we're creating a network of community health ambassadors that people can go out and then they can help their neighbors to get to these places, and they're committed to do it and committed to this healthy lifestyles. We have a lot of different facets of what we're doing. We definitely haven't mastered it yet, and we're constantly learning from others. I really appreciate Mark and that just the comments he's making. And I'm learning from him even on this podcast. I think.
And what I really like about the model that Holly's describing is it recognizes that, I have family who lives outside of a town in rural Michigan, and they could barely get their audio to work. There's no way they could support video. And so this more centralized location where you can really, boost up that bandwidth to get the connection, but it's not terribly, you're going into town anyway for groceries and whatnot. But what's really attractive about this model is it's surrounded by other supports. And so when you're hanging up, you're not by yourself in your family room or in the quiet room in the library kind of thing. You walk out and there's the community health ambassador or worker right there to say, okay, what'd you hear? I said, well, they said this, and I don't know what that means. And they said that, I need to cut back on this, but, we got the fair this weekend and I really want to go. And so, well, what if you substitute this for that? All that kind of stuff that really helps translate that information. There's a similar model or another telehealth model that I'm really excited about in southern Georgia, where it's addressing the maternity care desert, and same idea, taking high risk pregnant people, connecting them with a maternal and fetal medicine provider, but putting them in local health departments. So they hang up with the physician and then they walk out and the nurse says, all right, I've got your notes already. Let's follow up. What did you hear about your blood pressure and what do you have to do? So you have that immediate reinforcement rather than hanging up and then going on with your day. So I think that's a really exciting development that Holly's model is doing, as well as others across the country, that I think really has some promise and potential.
Yeah, I was going to ask, I'm so glad you said that, because I was going to ask in terms of follow-up or what comes after that, your turn with OnMed is what sort of, do people come away from that with a handout or sort of a next steps care, approach of some sort? Because I'm thinking about a lot of our agricultural workers that we communicate with our center, if there are things that would help them in communicating to their supervisors, individualized risks and needs that they may have for their health.
Thanks. That's a really good question. So what happens in our center is we're pretty resource rich. For one thing, we're right next to the Department of Public Health. And so we have, or to the Department of Human Resources. So we have a lot of resources there as far as health and handout that the folks can have access to as soon as they walk out of that station. But what we also have is from OnMed, they provide us with a monthly report. They don't provide us with individual patient information because that's protected, private, but they provide us with this information so that we can then host these different community conversations, and we can host different workshops surrounding the particular health needs that we see. As an example, we have nutrition needs. So we have different workshops there to promote healthy living, healthy eating. We also have extension that's closely aligned with us. They help to manage these locations. and they end up bringing in healthy foods. And we have recipe cards that teach people how to give them different ideas of how to cook some of these foods they may not be familiar with. The other thing that I think has been really impactful is if we have somebody with a lot of need that come out of that telehealth station, because of the state law in Alabama, they can only go into telehealth 4 times for the same condition before they have to see somebody face to face. So now we have these IPE clinics, interprofessional education. And so then we'll have a number of different professionals that will meet with them for primary care. And then we have folks in different pharmacy. We'll have people from physical therapy, also speech and hearing, also nutrition, dietetic. And that we schedule those appointments. And so I think the last time we had one of these clinics, we had 30 people signed up. But then they're not just meeting with one primary care provider. They're meeting with a whole team that's there to support them. And it seems a little intimidating at first, but we have these relationships formed and these relationships developed. And I think what you said about the folks who maybe aren't English speaking, we have great relationships in the communities also going out to, for example, the folks at the Mexican restaurant. They are some of our best customers and best patients, but they're also sharing the information with the people that come in, letting them know this is a safe space to go. And as far as the barrier for pay for the funding needs, we don't charge anything for folks to come in and use the services in the telehealth station. That's all sponsored. But then for the IPE clinics, there may be a sliding scale fee for some of the services if they're connecting with primary care.
And I think back to something that Mark said at the beginning of our conversation about training students that are rural aware. Has there been any incorporation of this into medical training? I'm thinking especially of maybe medical students that are training for, internal medicine, primary care, that this would be a really amazing opportunity to interact with patients and do some rounding, so to speak.
At Auburn University, we don't have a medical school here, but we are affiliated and closely associated with the College of Osteopathic Medicine, BCOM. And so those students do come over regularly for rural.
So, Mark, I did want to ask you a question because I know a lot of your research goes back to some of the disparities in outcomes and health outcomes. And maybe I'm taking kind of a step back. But I was just wondering if you could share about what some of these are, maybe provide some examples about, we've been talking about all this great development in addressing some of these needs, which is fantastic. And Holly, you've the work that you're doing there is just phenomenal. But what are some of these disparities and what are some of these differences in outcomes that we're seeing among patients?
Yeah, thanks for that. That question is a very depressing one because if you have 100 different outcomes, probably about 95 of them, rural populations have lower outcomes, worse performance, higher risk. Pick it. It's rare that there's many areas where rural populations are having better outcomes. And that sort of outlines the challenge. And it's multifaceted, and the causes are things as basic as the socioeconomics of the community. And what we've seen over the last 2-3 decades in particular is a real changing of the economic circumstances facing a lot of rural America. With some exceptions, obviously, but overall, and healthcare providers. So I mean, by that you mentioned, well, I guess Holly mentioned hospital closures. We talked about the erosion of services. We've talked about gaps in access to primary care providers and pharmacy and nursing facilities. All those kinds of, and home health. When you have 2 people who are admitted to the same condition, one to an urban hospital, one to a rural hospital. The urban patient is more likely to get home health care and have an easier transition to home, whereas the rural is often kind of sent home. There's no home health that can get out there often. They're sort of left to figure it out by themselves. Probably their follow-up care with their provider that they saw in the hospital might be harder to get to, and so they're missing that follow-up visit. Which puts them at higher risk for readmission. And so they're back in the hospital, they're more likely to be back in the hospital. The couple places where rural populations end up better, and one is something that if you grew up in rural areas, you're probably not surprised by, and that is the social connectedness. We can measure that in a lot of different ways, but it's people looking out for each other, which sounds
Mhm.
pretty Americana and apple pie kind of stuff, but that is a real fundamental issue. The smaller communities that local means has a number of advantages. It's um, easier to rally community support around something. If you have an issue, like we've heard some communities, have three drunk driving deaths by, adolescents in a 2-year period or something like that. That's it. We've had enough. And within 3 days, they can get basically everyone in the community together at the hospital boardroom on a Tuesday night and start, rolling up their sleeves and making a difference. And to make that work in larger areas is much more difficult. So understanding that and really leveraging the ability of rural communities to be nimble and not listening to those who tell them it can't be done is one of the real strengths of rural communities and their ability to make a difference.
Yeah, and I'll just follow up. You know, one of the things, Mark, that you highlighted at the State of the Science meeting, and I'll open up for both of you, but of course, the COVID-19 pandemic had pretty drastic impacts on healthcare. Holly, you mentioned hospital closures. But what has changed since the pandemic, good or bad or neutral for healthcare?
I think what we really understood from that was the fragility of the healthcare system writ large. And it's everything from how the one respiratory therapist that was working in the rural hospital, when her family member got sick, all of a sudden there was no care being done at the hospital that depended on that RT. It showed the duality of the system. In many states, we were seeing where the urban hospitals getting overcrowded, particularly during peaks, and the rural hospitals often saying, we have excess capacity, and they would work together to manage that surge. And the rural would, in some places, took COVID positive patients and sort of specialized in managing COVID, and others took the lower risk or the more pneumonia, for example, and brought them into the rural so that the urbans could do the more complex care. So it was a really nice example of how the healthcare system, I guess that's a big S or small s, I don't know, but probably a big S writ large, could really work together and understand, often under the guidance of state health departments and community health directors to roll up their sleeves and figure out how to get it done. Unfortunately, I think we saw a real spike in the distrust of science that we're still sort of recovering from. And I think there were a lot of lessons learned from that about messaging and how we can do better next time. And you can't say if there is a next time, but we'll say when. I think as we understand that there were, the likelihood of similar events is probably higher than it was in the past due to a number of circumstances, and we have to be ready for it. And there are investments that states and federal partners are putting in to be better prepared. For example, CDC has invested in creating an infrastructure that is already working to figure out how can we communicate better to all our stakeholders, including rural populations, rural health directors, so that we're better able to tailor the message and understand how all parties can get on board with the interventions that need to be done in the face of the next pandemic or other public health emergency.
I think Mark covered it. Steve, you really nailed it. I think as far as with Auburn, what we identified is that this space that we want to be in, not necessarily to deliver healthcare, but as far as to look at the innovations out there. I mean, we found a telehealth technology that we felt like could work. And because of COVID, people are a little more open to trying new things now. And they understand that there is no status quo anymore. We have to think outside the box. And that's one positive outcome, is that we realize there are other ways to bring healthcare to the person, that people don't necessarily have to come to the healthcare. So what are our opportunities for healthcare delivery? So we may have telehealth in these areas, but also we have telemetry kits that we'll be able to send home to these patients. And then these patients can then share their health statistics and their numbers with their clinician. And so people seem to be a little more open to that as long as they have the guidance and they have the quality of care and the continuity of care. So that's what we've seen around here. And I'm, I'm happy that Auburn University is willing to get into this space. And then also we leverage our relationship with the extension system. We have one office in every single county in the community, and people already have relationships with extension. You think extension, you think they go to them already. And so they're able to really communicate with the campus at large about what they see the needs in the community. And then the community is willing to trust them because they have been there. They've stood the test of time.
Yeah, those are great points, Holly. I think I'm glad you mentioned telehealth because there's two things I want to say about that. The first is, I think pre-pandemic, I was always using the phrase "the promise of telehealth" because I think it was exciting, but we hadn't really seen it take off as much as we had thought it should. And then during the pandemic, paradoxically, and ever since, I think we still see this, that urban populations are using telehealth more regularly than rural. And we've talked about the broadband limitation for that. I mean, when I transitioned, it was easy to fire up my iPhone or to pull up my laptop and launch Zoom. I'm on Zoom 8 hours a day. It's easy to connect with your provider that way. And I am on Google Fiber, so the connection was valid. But take that away, and it's a much harder gap. And so I am concerned where, notwithstanding the wonderful project of OnMed and others like it that Holly's been speaking about, nationally we have this reversal, which is paradoxical. And I would love to figure out, I mean, we know some of the barriers, but address these barriers and find the solutions to giving that telehealth option to more rural members. Holly also mentioned telemonitoring, which I think is really exciting. We have a project at my center that is remote monitoring blood pressure using cuffs that link to the cell system. So rather in the past, it used to be, that's a next generation. A lot of the existing work had been, you have the cuff and then you have to Bluetooth it to your phone, and I can never get my headphones to connect on the first 3 tries, but so that was a challenge. And now it's just done, without even knowing about it, and the light blinks and it's already uploaded. And so imagine again, you're a healthcare provider. You wake up in the morning, you fire up your patient panel, and there are 3 people who have a red line or red shaded row from that morning's data. How much better are we able to address that, in near real time, as close as we'll ever get, without asking them to come in and get checked out? We can have a risk-based model and say, all right, let me call these 3 people on the phone and figure out what we need to do about this and what's going on. Take it again. What were you doing when you took it? Did you have pizza last night, which has a whole bunch of salt, or whatever it is? And again, that's a way to really lower those access barriers.
So I want to ask a question to Holly, but what I'm getting at is I'm hearing about all these changes, and sometimes change is hard and comes with a bit of kind of an aversion to going into something new. But also, kind of to counter that a little bit, we've heard about how rural communities have a strong sense of community and really, they can. I'll take all this out, but they can kind of harmonize quickly around challenges, right? So what I want to ask Holly is, what have you seen with the OnMed program as far as it's change, it's new, but it's also, are you seeing community members reaching out and saying, no, actually, this is really helpful. Like, this is great. This is something that's new, and kind of this word of mouth that's happening.
It's funny because when we first started introducing this to our communities, people were saying, oh, the older people won't want to do it. They're going to be resistant. And what we found is this is the opposite. They love it. They go in, and it's this private environment where they meet face to face with this clinician. The clinician is life size, and all they have to do is prep with that. So they go in, they press this button that says start, and then the clinician actually fills out all of the paperwork for them. They don't even have to fill out any paperwork. So we don't have to sign things on the screen, but they don't have to type in their name and type in their address 100 different times. It's really much more efficient for people. And what we also realize is you have to, what is that? You can lead a horse to water, but you can't make him drink. You have to make him drink to a certain extent. So we have it out there. It's free. It can do 85% of what you can do in an office. But still, if someone, I mean, I'd be nervous if I'd never been. So
Mhm.
what we're doing with these demonstrations, as I mentioned, we bring the churches in. So we go out, we take the van, and we bring people to the center and have them try it out. So we've had senior center individuals come before that's when you need to catch them. Don't wait till they're sick. I mean, you don't want to go to a new place when you're sick. You want to already feel comfortable going into this place. So we've had Rotary Club, Civitarian Club, our Main Street organization. We've had county commission members, city council members, and which is senior center nurses, a nursing group, and then also the just any kind of churches. But so that's been really helpful. But what we're finding is, word of mouth. We just added another question on our survey that folks use when they come in about the quality of their service, asking how they heard about us. I don't have the data for you yet, but I'm interested. What is working? And my guess would be word of mouth. So I think one of the most impactful things we've done is we've created this network of health ambassadors. And I mentioned them earlier. We have 33 health ambassadors in Chambers County in the city of Lafayette. And these are mainly, it's kind of interesting. We have youth, high school students, and we have retirees. And so they're both out there spreading the gospel. They're getting their friends to come in and they're making it feel like a safe space. And they're out there promoting all the good things. So that's what it takes. It doesn't take Holly Cost from Auburn University saying this is a good, they don't know me and trust me yet. But it really takes the people in the community. And that's what I've been pleasantly surprised about. But it's taking a lot of work. It doesn't just happen overnight. You have to really get out there. So uh, it's worked.
Yeah, no, that's really cool to hear. And yeah, I can hear kind of the excitement and the passion when you're sharing that, which is really great because I know that there's just a huge impact that's being made. Um, I think we're kind of starting to wrap up. I know we can kind of have one more question for both of you, but Lisa, did you have anything you wanted to add?
Well, I was just thinking as you were talking, Holly, that a lot of the things that I hear you saying about, we go get them, we provide transportation, we work with the churches. A lot of those are things that we've talked about in terms of community health with agricultural workers in so many different ways. Um, and so I can see a lot of crossover in terms of what you all are offering and the approach that you're taking and how that we might um, try to think about how we can just make sure that those opportunities are something that agricultural workers know about and can take advantage of, and especially as those networks grow across the South, and a lot of our agricultural workers don't necessarily stay in one place throughout the year. And so hopefully that would be a way that as you maybe move through growing season, you might develop trust with this way of getting healthcare. And then when you find yourself in a new location, you think, okay, yeah, I know about that. I already did that before. And I know that that's a safe, trustworthy place to go. So it's great.
Can I ask Holly what might be a softball question? Um,
Please.
Holly, I'm really interested in the med model and how you've been tailoring it, or maybe not the model itself, but how you've been tailoring the talking about it for rural populations. And what have you learned, and what have you had to adjust in order to increase its acceptability by your target population?
I think the best way I could answer that question is to say we wade into the water, Jim. And so when we're looking at communities and you talk about those health outcomes and those health factors, I'm looking at these maps right near of Alabama and I see the dark counties, they're all really rural, they're in West Alabama. And so what we do is we identify communities that we know have the health need, they have the poor health outcomes, poor health factors. And then we start by talking to their community leaders. And these are the official leaders. We'll talk with the county commissioners, we'll talk with the hospitals, we'll talk with the city council members, and we bring them all in as a group. Talk to them about what our model is, And then we ask them, what do you see as your needs and your priorities? And is this something you want to partner? And if they do, then our next step is to have a community conversation. So then we bring in a broader group of stakeholders, about 20 to 30, to say, again, what are your health priorities? What are your barriers to access? This is this healthcare station. Who's going to use it? Are you interested in using it? Do you want to jump on a van and go and see an existing care station? And we'll go check that out. And so, again, just introducing it over and over to multiple groups, and being real open to whatever questions or hesitancy they do have. But I guess that's my best answer is just we do wait into, but we have a pretty lockstep model because we meet with these leaders. They like it. We meet with the community members. We find out where's the best place to locate this? How are they going to have to buy in? And then from there, we do the implementation, but it's continual improvement. We're always evaluating and assessing just the patient satisfaction. And then what we are hoping is to see these better health outcomes, but that's going to take a while to see.
Yeah, and actually, Mark, you kind of asked a really great question to sort of as we're wrapping up. I did want to ask both of you, and Holly, I think you kind of addressed it here, recommendations that you have for novel or adapted healthcare delivery models. And it sounds like, from what you said, it's really, going in slowly, getting community feedback, evaluating, adapting as needed, right? Addressing some of those concerns as needed. But yeah, do either of you have any other recommendations for just ways to reach some of those populations that have previously not been reached as much?
I think that as some of the work that I've done has really shown, surprisingly, that local leadership is usually the secret sauce and what makes a difference, and empowering them to address their priorities rather than coming in and saying, hey, I'm from UNC and I've got the solution for your behavioral health needs. And they say, yeah, we're more interested in diabetes care. Like, that's great. I'm here with a behavioral health solution. And so that means listening to them, empowering them. What I really liked about what Holly's model is not only is it listening and really engaging the community, but it's tailoring it. And I can't remember the particular places, but in one place we put it in a senior center, and another place we put it somewhere else, because that's what they wanted and that's what they needed and that's what they thought would work best. It's not super scalable, but it really is the solution to recognize that innovation is going to happen in that local area. Hearst has been doing this. There's a program called Our Moms, which is designed to let local communities innovate around their maternal health solution. And R Corp, which is addressing their opioid crisis, allowing the communities to come up with what they want to do, what they think their priority is, and then learning from those and building up, here's one general model that you can tailor to what's going to work for your community. That, I think, is probably the best path forward.
No, I appreciate that. One population I haven't mentioned, I did touch on as a healthcare professional, that we are connecting well with the hospitals. So we're getting input from the hospitals, and in one community, the hospital was even hesitant about what we're doing might impact just their services and their patient base that comes in, because we don't charge, they do charge. And so what we're looking is, how can we intersect those? So how could possibly their nurses or their nurse practitioners be a part of the OnMed network, so they can deliver services across the county where folks may not necessarily be able to drop all the way to the hospital. And if they meet their healthcare professionals through telehealth, then they say, oh, okay, well, I know you're just 20 miles away. Now I'm going to ride there because I met you and you're not scared and I know you care. And then the other population that we're working well with is EMS, emergency management services. So in 2 of our communities, we have the fire chief who is working very closely with us, and they're able to tell us, okay, this is what we're seeing from our frequent flyers, people that call in, and we see them all the time, and this is what we need help with. And so we're taking some of that off of them. And again, they're the trusted people in the community, so they can say, all right, Miss Jones, next time you need help with this, you need to go over to this telehealth station, and I'm going to get you to have a visit over there to try it out first. And it works. People trust Chief Duty. People trust Chief Gibbs. So that's another population that we've really got on board as partners. And I really like what Mark was saying. We do not profess to know all. We don't. And that's one of the first things I say about them. I can't tell you what you need. You tell me what you need. We don't have all the answers, but let's figure them out.
That's great. That's great. Well, I want to thank Mark and Holly. I want to thank you both so much for coming on Science by the Slice and sharing today. What a great conversation, uplifting conversation, challenging conversation, but it's so crucial and so critically to have. And the work that you're both doing is amazing. And of course, Lisa, thank you so much for co-hosting and sharing all that you bring in today. So I think we can go ahead and wrap up, but it's been a great episode. Any final thoughts before we close out?
Appreciate the opportunity.
Thanks for shedding
Yeah.
a light
Thank you
on rural
both.
health. Yeah.
All right. Goodbye.